who have anyway kept their interest in complete dentures alive, even in these days, in these digital days, because now everything is digital, isn't it, nowadays? And complete dentures looks oh so old-fashioned. But the fact is, it is not that old fashioned, because even in the digital era, you need to be, what shall I say, aware and capable of performing certain basic procedures, without which your digital systems will not give you proper results. You understood? So this communities do have a significance even today, but for some reason, it's considered as something old fashioned. But I wish to thank all the delegates who have decided to listen to this small presentation. Obviously, one cannot go into the entire all the details about complete dangers within the time available, but a few things we can definitely I can definitely share with you. I hope you can see the slides. No, hello,
Yes, sir.
Yes, Doctor, it is visible and your voice is also clear.
clear. All right. So the title that was chosen for this particular discussion was "Tips for Successful Complete Dentures." Now, actually, I would have liked to be another this thing, and that is actually engineering complete dentures. That would have been the better title, but that doesn't matter. Well, it's all the same thing. But since you are all in the practice field and not exactly into teaching and things like that, I thought this will be the better heading: tips for successful dentures. All right. So in this discussion or this interaction, I will just go through the various steps of how a complete danger finally comes alive. Okay, and with some suggestions from my side as to how to be successful in that effort, in endeavor, right? Uh, with some from my point of view, you and then I do wish that we have a lot of interaction at the end, where you can raise all your questions, doubts, whatever you want. And I shall try my level best to reply to those. And okay, fine. So let's start. Before we start any endeavor, it's customary to to invoke the blessings of the universe or God or whatever you may call it. And I have chosen this sloka from the Brihadaranya Upanishad, which is probably familiar to many of you. Asatoma Sadgamaya, Tamasoma Jyotirgamaya, Mrityoma Amrudam Gamaya. That the basic meaning is lead us from the unreal to the real, from darkness to light, from death to eternal life. Om Shanti, Shanti, Shanti. And I sincerely hope that the second line of this invocation comes true at the end of this presentation. Not that I am implying that you are all in the dark or anything like that, but there are certain areas which are not very clear to many of us. So I will assume that by the end of it, I will be able to I would have thrown some light into those slightly dim areas in the field of complete dentures. Okay. Now the first question that we need to address is, what is the need for complete? What is the need for complete dentures? So I mean, do we really need complete dentures these days? Because now the mantra is save the teeth at whatever cost. Whatever cost, you save your teeth. And we have so many techniques of saving our teeth. So the fact of the matter is, nowadays, the people needing complete dentures have drastically fallen, and this has had a great impact in the way education of incomplete dangers is imparted to students. Most of you must have experienced it, or not most of you, many of you. I'm not saying all of you must have experienced this in during your study days. That is, there are simply not enough complete danger patients for you to practice and learn. And if the college has a postgraduate program in prosthodontics, then the number of student patients available for you also drastically falls even further, because the first priority in any college, in any department, is to give patients for the postgraduates. So whatever remains after that is what the poor undergraduates are able to do something on, and that is simply not enough, right? So the question is there a need for complete dentures, right? And the answer to that would be, this is just a picture of the original estate. Uh, a little statistics. Just no, don't worry. We are not going in. It's not a theoretical dialogue on complete dentures, but just to keep things in perspective, a little statistics. Uh, yes. Now, evangelism is an irreversible and debilitating condition and is termed as a final marker of disease burden for oral health. That is, the final marker of disease burden, meaning once the teeth are all gone, right, then that's the end of all the disease burden, oral disease burden, as far as the teeth are concerned. Because when the teeth are gone, there is no more disease there, right? There is no more caries, no more periodontitis, no, nothing is there. So once all the teeth are gone, that is the end of the disease burden in oral health. But the fact is, when one ends, something else begins, and that is the disability part of it. Now the percentage of US is 4.9%. So you can see how much they must be learning to do complete dentures. But in India, still, well, it's somewhat encouraging, 16.3%. But that's not a great thing, because this 16.3% is distributed in a population of nearly 1.4 crores. So it's a big number, but unfortunately, somehow it doesn't translate into people coming for treatment for various reasons. All right. So this is the small amount of statistics. Yes. Now I want to ask this audience or the participants one simple question. So that's why I put the heading first things first. Are we all convinced? I'm sure we are, but I just want asking a rhetorical question. Are we convinced that being totally or partially edentulous is a disability? Now, this is one of the drawbacks of having this virtual seminars, because I cannot personally ask you the question as if you are in a class or in a real physical interaction. Because so I have to ask you this question, and maybe I have to give the answer also. That the question is this: do we all consider partial or total evangelousness as a disability? I am sure every one of us sitting here will give a resounding yes. Yes, definitely it's a disability. That's why we are rehabilitating, isn't it? If it is not a disability, why give dentures in the first place? So definitely it's a disability. But let me give you a small, small uncomfortable surprise. Hmm? And the surprise is this: unfortunately, no. Now that will shock you sometimes. Why I am saying no is not that we are saying no, but internationally there are organizations, professional and otherwise, who are engaged in managing disability in general. So disability in general would mean loss of limbs, loss of cognizing ability, loss of speech, loss of eyesight. These are all disabilities. So there are international organizations which manage and classify and come out with techniques to manage this. But in their books, in their literature, complete evangelism or even any type of evangelism is not considered a disability, and though they don't explicitly say so, their silence becomes deafeningly loud, because their silence speaks volumes. They simply ignore total evangelisms, right? And the fact of the matter is, the question is then why are they ignoring our evangelousness as a disability? Is because, and the reason is even more amusing. They say that that's because evangelism can be easily managed. That's the word it's used. Easily managed with dentures. So it seems that does not warrant it to be considered as a disability. I don't know whether the dental profession in India, or for that matter, dental profession anywhere, is aware that our edentullousness, which we consider as a great disability, is not even given a not even given a passing mention in the literature of this particular aspect of medical science, which is actually called rehabilitation engineering. There's a whole branch of science there, rehabilitation engineering. But the fact is, and the irony is, assistive technology, as it is also called, which engages in managing disability, uses almost all the techniques we employ while engaging with gently disabled individuals. So if you go, no, we're not going into details about it, just for your information, I'm telling you. So be anybody who is in the IDA, who is actively involved in IDA at the national level, can may please take this up with the IDA top brass, and and tell them that we are not considered a disability by the international associations who are dealing with disability. Uh, so that is a big lacuna in our work actually. Right. Fine. Now, this is all. What is the impact of evangelism on systemic health? As this is all very straightforward. There's nothing new here. And lower intake of fruits and vegetables, more importantly, fiber, because you obviously can't chew these things. Vegetables and fruits and fibrous foods need a lot of chewing. Without teeth, that's not possible. So what happens? Increased rates of chronic inflammatory changes of gastric mucosa, increased rate of gastrointestinal and pancreatic cancers. Then decreased daily function, physical activity, because obviously when you don't take sufficient food with all the vitamins and minerals necessary, your functioning also is affected. Then sometimes it seems that people they suffer from sleep apnea as well, right? Now, most of us or most of you have heard in your college days that when you start the topic of complete dentures, the usual starting is diagnosis and treatment planning. This is the usual term we all use, and nothing wrong in that. But one author, the author's name is not very not very which I say necessary here, but still, the author's name is Engelmeyer. He in a particular book, he has used the word evaluation and treatment planning. He has not used the word diagnosis and treatment planning, and I think that is the more correct usage, because if somebody were to ask you what is the diagnosis of a person who comes to you without teeth, the diagnosis is simple: either partial dangerousness or total dangerousness. Finished. The diagnosis is over. Then the question will come, then what are we doing after that? We have a long 3 or 4 page long sheet, list of things that we are supposed to examine, right? Then what is that then? Yes, that is the evaluation of the dangerousness, right? What is the nature of the dangerous ridge? What is the nature of the attachment of the mucosa to the ridge? How is the frenum attached? What is the type of saliva? What is that? What is this? So these are all evaluating the dangerous condition. That is not the diagnosis. The diagnosis is over. Total dangerousness or partial dangerousness. But after that, we evaluate the situation, right? So the correct terminology, I believe, should be evaluation and treatment planning. And it's needless to say, a thorough examination, evaluation, and optimum treatment planning, seguing to accommodate patient's wishes, is mandatory. So we need to do a thorough examination, evaluate the condition, and do some treatment planning, optimum treatment planning. But they should all segue, meaning they should all taper or be in line with the patient's wishes. That's mandatory, because as we will see later, ignoring or sidestepping the patient's wishes is suicidal as far as complete denture fabrication is concerned. We'll come to that in a minute, very briefly. The evaluation must be of 3 aspects: the ridge, the mucosa, and the temporomandibular joint. So whether you do there are so many things you can do, but minimum you should be looking into the quality of the ridge, the quantity of the ridge, right? The mucosa. What is the type of mucosa? Is it flabby? Is it inflamed? Right? Has it got any white patches? Or is it okay? And then of course, last but not the least, the temporomandibular joint, because that's the one that's going to move your edentulous jaw, at least the lower jaw, right? So the health of the DMJ is also to be examined. So minimum three things you must examine. Yes. Now comes the interesting part, or the important part. There is, unlike other specialities of dentistry or other yeah, other specialties of dentistry, except maybe periodontics. There is a special significance in the dental dentist patient relationship, right? Now, what is that special relationship? You see, success in dental engineering is not confined to technical skills alone. Okay, and recently I read an article which said that studies have shown that a technically perfect denture, meaning everything is perfect, the teeth are perfect, the intaglio is perfect, the french, everything is perfect. Yet that is not a sure sign. It's not a guarantee that your denture will be a success as far as the patient is concerned. For the patient perspective, if it has to be a success, there is something else too, right? And that something else is not related to the technical skills alone. Okay? Yes, and for getting there, to make it a success, most important thing is creating a warm and trusting relationship with the patient. That is very, very important. And if we fail to do that, however technically perfect your denture is, it may not be a success as far as patient usage is concerned. Yes, and that's because the dentist's attitude will get incorporated into the denture. So if the dentist's attitude is of a warm and understanding type, that attitude somehow mixes itself with the dough used to pack the denture, right? And that will help the patient use it better. Okay, and if that doesn't happen, or if the dentist patient relationship is not very warm and cordial, then the results will be inevitably disastrous. As this famous saying you must have heard earlier, meet the mind of the patient before you meet the mouth of the patient. I think was said by a famous person called Divan. Some of you may remember Divan, right? So that is this is especially true for community dentists. Or for any processes, forget about community, for any processes, one should look into the patient's mind, understand what the patient wants, and then only you look into the patient's mouth. Otherwise, the results may not be as good as you would wish it to be. Now, now why is that so? Because denture making is currently, now you can see two words there, hand slash ham. You are more familiar with the terms CAD and CAM. Now I think today is the digital. Today we have the digital era. Everything goes digital, right? And you most of the participants here must have listened to at least a couple of seminars, webinars, conferences, whatever, on digital dentistry. That is the in thing today. But as of today, we have not CAD, not computer aided design, we have a hand aided design and a hand aided manufacturing process. So it's our, and we still do things with our hand, majority of us. Of course, maybe in another 5 years or 10 years, the whole thing would be taken over by robots or by the computer. Even today, most of the fixed processes is being taken over by the computer, but company dangers are still, sort of, what shall I say, are not still amenable fully to the digital world, right? And therefore, we should look into what's going on when you make a denture for a patient. And there we have three heroes. In complete denture fabrication, we have three heroes. One is you, of course, the patient, yes. Now there is a third party also involved in the success of your dentures, and that is the family of the patient and the well-wishers of the patient. Now they can play a very important role in the success or failure of your dentures. And therefore, we'll see. And therefore, unless we manage all the three, your dentures will may not be a success. Okay? Now we all agree that till such time that a patient starts using our dentures regularly, the denture cannot be considered a success. Now this is an ideal. This is an ideal situation, but if you think your dentures are should be a success, then the patient should be able to wear it comfortably, right, for a long time, regularly, not when he goes out for a social function, or when she goes out for the market, or when she goes out for a marriage. No, it's not like that. Comfortably, the patient must be able to use it regularly. Then and then only we can say that our dentures are a success, right? And unless patients are comfortable while using the dentures, they will not use them. That is very simple. Unless you are comfortable with the dress you are wearing or with the shoes that you are wearing, you are not going to wear it. You will throw it away. And you will find some other shoes, the old ones maybe, which are more comfortable. And a comfortable denture just doesn't happen out of the blue. It has to be engineered. You have to make it comfortable, right? And what we are going to see from now on is how to try and make a denture comfortable for the patient, right? Now, one small classification of patients. We are not going into the theory. I mean, there are so many classifications. We are not interested in all that because it's a purely practical, practice-oriented presentation. Theory is not is not the time to talk about theory, but a small classification. Essentially, there are two types of patients: realistic patients and unrealistic patients. I mean, from the words itself, it is very clear. You have met some people like this. Realistic patients are patients who are very practical in their approach towards any treatment, and they know that there are difficulties. And when you, the dentist, tells them that, see, there are issues. Initially, you will have some problems, but in the long run, everything gets settled if you follow my instructions. So please be a little patient. Don't be in a hurry to use your dentures in the way that you used your natural teeth earlier. So such people, okay, fine, I accept that. They will accept that, and they are willing to wait and listen to your instructions. But the unrealistic variety, they are people, let's say, a little impatient. They want things from day one to take place normally, which is not possible. And they are also unrealistic with something else also. One is they are unrealistic in their expectation as far as your availability is concerned. They think that you, the dentist, must be available 24/7, right? Whenever they have a complaint, you must be ready to solve them. They're not bothered about whether you have a life or you have got other things to do, right? So they expect you to be at their beck and call. That is okay. Well, doctors, that is what we doctors are supposed to be. Be at the beck and call of your needy patients. But that's not the issue. The more pragmatic issue is such patients also expect you to keep on treating them, or keep on removing their complaints without giving you any payment. They want you to do it free for them. Okay, once or twice maybe you can oblige, but if it goes on for year after month after month, and there is nothing, no payment, you are likely to be very little bit irritated and frustrated. But there are people like that. So this is just for information, and we have to. Everyone has got their own methods of dealing with them. I am not going to talk about that now. But that is up to you. But there are people like that. I'm sure you must have met at least a couple of them in the short practice life that most of you have had. Now, what are the stages of denture fabrication? It is a very straightforward question. The first, of course, is impressioning. I have converted a noun into a verb, impressioning. Impression means to make an impression, and an impression is a negative registration of anything. Generally, an impression is a negative registration of anything. It's called an impression, right? Now, a preliminary impression, as per the glossary of prosthodontic terms, or what we call the dictionary of prosthodontics, an impression made for the purpose of diagnosis or for the construction of a trait. And that is the definition of a preliminary impression, or some people call it the initial impression, diagnostic impression, or whatever, right? So this is, and but please, one small clarification here. Today you hear the word digital impression. I'm sure everybody here has heard the term digital impression. Hmm? And we all know with what that is made. It's made with those intraoral scanners. But please remember that that usage is not correct. You understood? Because if you use an intraoral camera, we are not obtaining a negative registration. We are obtaining a positive registration. It's virtual, all right, but it's a positive image. You actually see the tooth, you actually see the edentulous area on the computer screen, right? It's not a negative image. So the term digital impression, I think, is not fully tenable and should require a little bit of look into whether we should continue to use that word. Anyway, this is for your information. That's all. And preliminary impressions, as you know, are made with stock trays. So how to all these trays? I mean, everybody knows these things. There are a lot of stock trays. You can see the rim lock trays at the left corner of your screen, rim lock, and the others are the trays that you are available here in India, which are relatively less costlier. The rim lock trays are a little more expensive. That's up to you, and you have perforated, non-perforated, metal, or sometimes resin, made of plastic, right? And now the question is, what type of ready-made tray? Ready-made tray means stock trays is there. Now, plastic trays are preferable when the patient's medical status validates the use of disposable trays. Because today we know there are a lot of medical problems like hepatitis or AIDS or even COVID. So, in such cases, when we would like to dispose of the trays after one single use, then not naturally the plastic trays are preferred. Otherwise, everybody uses metal trays because they are sturdy in handling and easy to clean, can be reused after sterilization, and there are different varieties available to meet different needs. So most of us use metal trays, perforated or non-perforated, right? Rim lock or non-rim lock, right? But in case there is a situation where the patient is afflicted with some transmissible disease like TB or anything of the then we may need to dispose of the tray. In that case, you will have to start using the plastic trays. Now, tray selection made simple. There are three parameters: the antero-posterior dimension, that's the length; the mediolateral dimension, the width; and the supra-inferior dimension, the height. Okay. Now the maxillary. You see how to introduce the tray. I think most of us know that. That is, you have to rotate the tray into the mouth. I wish we could have a practical demonstration of these things. Unfortunately, that is not practical for various reasons. Because telling these things theoretically is of absolutely limited use. All I can help you tell you, show you the picture. That is, you can see this is how you reflect the cheek on that side, insert the tray at an angle, and rotate it into the mouth. I think all of us do that, I'm sure. Antero-posterior dimension. Place the posterior end of the tray to the hamular notch with the anterior end down so the notch can be easily visualized. Once the tray is placed there, rotate the anterior part of the tray upward to seat in the anterior area. See, you first see, look, you can see the pictures are there. First, you introduce the tray, rotate the tray and introduce it into the mouth. Then have a look at the hamular notch. First, place your tray in the hamular notch first. Then pull or lift the tray upwards so that it now seats on the anterior ridge as well. Right? And of course, there must be some space between the palate, they're talking of the lower, of course, and the tray. That is the space for your impression material. So there should be some space, okay? Otherwise, the material will get pushed out. Now, an underextended tray is more detrimental to the preliminary impression as the impression tends to be short or unsupported by the tray. This leads to distortion while making the cast and eventually to faulty underextended custom trays. So, whenever you select a tray, please ensure that your tray is sufficiently big, right? Sufficiently big. I'm not saying you should use too much of a big tray because that will be difficult to put it into the mouth and take it out as well. But definitely don't use a tray which simply does not cover the entire edentulous ridge up till the hamular notch. The hamular notch is a very important part of your impressioning, and if you miss that, you will have a problem. The other important part is the posterior palatal seal area, right? Uh, Now, a word of caution here: 99% of trays, stop trays, metal stop trays I'm talking about, do not extend up till the soft palate. You have all seen that. 99% of your metal trays, I'm leaving that 1% out because the very expensive, there are expensive rimlock trays available in the market. They are pretty expensive. And most of us don't are not willing to spend that much money for those trays. But therefore, we use the Indian made trays, and 99% of them you have seen will extend maybe three-fourths of the hard palate. Three-fourths of the hard palate. That a little bit of the hard palate is also left uncovered, and of course, I did not say the soft palate is also left uncovered. And now using and we can, and what can we do about it? I mean, that's the company who supplies those trays. So, but the point is, we should recognize that the fact is, in other words, you don't take a tray from your inventory and put it in the mouth and start making the impression. It's not like that. Knowing this fact, next time you use a stock tray, you insert the tray in the mouth. Use a mouth mirror, or you can use direct vision. You will see that the posterior border of the tray, the hamla knots and all may be covered. That's okay, but the posterior part of the tray will not cover the entire hard palate, right? And definitely not cover the soft palate. Now, both are very important. Your stock tray must cover the hard palate and a little portion of the soft palate. Now the question is, what are we going to do now? This is a steel tray, a metal tray. You can't extend. How can we extend it? Now there are two ways of doing it, but that depends on the material that you are using. I'm sure the majority of us are using impression compound. So I sincerely wish I could physically be in front of you, right? So that I can ask you personally what type of impression material you are using. But I'm assuming this, that 95% of people would be using impression compound. There may be a few people who use alginate. And there may be very few people, very few people who will be using the heavy body or putty and elastomeric material. I mean, I don't know whether anybody is there in this gathering who is using putty to make a primary impression. If you do that, well, hats off to you. But majority of us use compound, some of us use alginate, right? Now, if you are using alginate for your primary impression, now I can see some, and maybe I imagine I can see some frowns on your face. Alginate for an dangerous patient? Well, what is wrong in that? I mean, there's nothing wrong in that. It's not mentioned that you should use only compound for a primary impression, right? You can use alginate, nothing wrong with that. Okay, so, but if you're using alginate, we can extend the posterior border of the tray, right? And that extension is done with wax. When some area alone is short and the general fit of the tray is perfect, wax may be added to the tray to make up for the short flange area, posterior border area, whatever. Now, how to do that? Well, as I told you, I sincerely wish I could be with you physically and demonstrate how to actually do it. It's not a big thing. It's not too much of a technically complex procedure, but yet if you see it once, you will appreciate it better. All right. So as you can see here, the tray extends only up to here, right? Now this light pink is the wax, which you can add to the posterior border so that it extends right up to the distobuccal sulcus. Right? All right. Now, in case you are using wax, this is for the tray margin. For the posterior border, you have to attach the wax to the posterior border of the tray, right? And let me see whether I have that slide with me. I know it's not there. So that's what I said. These things, it needs a practical demonstration. Otherwise, well, I hope you get what I'm trying to tell you. So this is the margin. You can put wax there. Wax means don't take the wax, the hard modeling wax, and just with your fingers press it and keep it there. No, you have to flame it, soften it, roll it into a rope or maybe a small or should I, a small oval structure, place it on the lingual, on the that border there, insert it into the mouth, and ask the patient to move the jaw right and left, like you do for your bottom holding, right? And that will ensure that the soft wax is neatly molded into that surface. Simply putting some wax there and then loading with alginate, yeah, you will get an impression, no doubt, and it may be extended also, but you will get a little better impression if you put the soft wax at that border, okay, softened wax, insert it into the mouth, and ask the patient to open the mouth if you want, but side to side movements of the mandible. That will mold like you do for your bottom molding. Okay, and that will give you a nicely molded distobuccal border. And I'm repeating, the distobuccal border is a very, very essential part of your impression. Okay, and one more small tip for you. Whenever you make any impression or whenever you do any border molding, please instruct the patient to keep the mouth half open, because patients have a tendency to keep their mouth open or open it as wide as they can, because that's a natural instinct. When a dentist comes to the patient feels that it is their responsibility to open the mouth as wide as they can. Fair enough if you are making an examination. But if you are making an impression, that will create like havoc for your impression. Because when the mouth is opened, the distobuccal sulcus is almost obliterated or it becomes shallower, right? And if you make an impression in that condition, yeah, your impression will have a nice border, all those stuff, but that is only when the patient is keeping the mouth open. When the patient closes the mouth, there will be a big gap between the tray border and the histobuccal sulcus. And believe me, if you have that sort of a primary impression, obviously, inevitably, your special tray will also have only that much of extension. And if your special tray has only that much of extension, your border molding, you will still do the border molding, but getting retention, you can forget about it. You will not get your retention because when the person sitting at rest, the distobuccal area is completely not in the impression, and if that is not there in the impression, your osteopalatal seal, okay, or trigomaxillary seal as they call it, will not be there, and your denture will not have retention. It all starts with the primary impression. So make sure that your primary impression is really good, properly extended or overextended. Let it be overextended is okay, no problem. Let it be overextended, but underextension would be disastrous. Okay, and to get a properly extended or slash overextended border, the patient should be repeatedly instructed, not at the beginning. Okay, keep your mouth relaxed, fine, and then that particular time it will be like that. Next time you take it, the patient again opens the mouth wide. So repeatedly you have to tell the patient, please relax your mouth. Open your mouth just half. Okay, so this must be the mantra while the impression is being made. Right? You should chant it like a mantra to the patient. Now in the case of the mandibular, yes, again, rotate the tray into the mouth as you can see here. Don't, okay, and then I think the pictures are self-explanatory. You rotate it into the mouth. Now again, there is the anteroposterior dimension. Place the posterior end of the tray with the retromolar pad with the anterior end up, so the pad can be easily visualized. Once the tray is placed there, rotate the anterior part of the tray downward to seat the anterior area. So insert the tray, rotate and insert, lift it up so that you can see whether the tray is covering the retromolar pad. Retromolar pad should be covered with your impression tray. And once the tray is placed there, you can rotate the anterior part of the tray downward to seat in the anterior area. Right? So this is all okay. You can see the tray is lifted up to see the retromolar pad. Retromolar pad is not visible in the picture, but obviously there is a retromolar pad in the back. Okay, and then once you can visualize it, put the lower the tray onto the ridge. Now, yes, now a small bit of, again, one tip. In occasionally we will go like that. A procedure will be described and a small tip to make it perfect. Now in the case of the upper, I told you, if you are using alginate, fine. You can use wax, and I suggest that you should use wax at the distobuccal border and do the molding as I have told you. Right? That is, well, doesn't matter whether the tray is there or not. You use a little soft wax in that region and do the molding. That is to make it 100% sure that the distobuccal area is copied. All right. Then when it comes to the lower, the same, mind you, if you're, this is possible only if you're using alginate. If you're using compound, the technique is a little different, right? I'll tell you that in a minute. Now, the retromyloid fossa region is sadly a common site of underextension. Careful palpation of the area digitally or using a mouth mirror reveals a large area available for impression individually. Impression trays must therefore be adequately extended in this area to support the impression material and to enable you to capture that area, right? So, yes, can you see this picture? As you can see, this is the stop tray has now been beaded with wax. Okay, again I'm repeating, this is only possible with alginate. With compound, you simply can't use wax because the wax will get softened and they will get pushed out. So using impression compound, wax. So you can bead the other areas, but when you look at the distolingual area, you can see that it has got a nice, it looks like a, actually this looks like a final, a bottom molded special tray. Yes, this must be the appearance of your stop tray. Now you may think, okay, stop tray, what is there? One of the misconceptions that many of us have is that, oh, what is the necessity for a good primary impression? Little here and there, nothing is that doesn't matter, because ultimately I'm going to make one more impression, the final impression. So when you make the final impression, I can correct whatever mistakes here, I have whatever little problems here, it will be corrected there. Very, very sorry to say, please don't think like that, right? If your primary impression is not good, right, by default, your special tray also will not be good. And if your special tray is not good, right, you will not be able to correct the deficiencies that have happened during the primary impression. Please don't think that the secondary impression is a step where you can wash away all the sins that you have committed for your primary impression. Simply impossible, right? And this is another area where if your impression is not properly extended in the distolingual area or retromyloid area, you can you will it's impossible to get a proper bottom molding done in the next step, the final impression stage. Impossible to get your proper bottom molding done, right? So irrespective of whether the tray is extending in the lingual area or not, please put some soft wax over the border like you see in the picture. Place it into the patient's mouth. Ask the patient to do the steps that you tell them when you're doing a bottom molding, like protrude the tongue out, lift the tongue, move, push the tongue to touch the cheek on either side, protrude the tongue again, and you will get a border like this. And if you get a border like this in your stop tray, right, your primary impression will be a very good impression. And your primary impression is good, the diagnostic cast will be good. The cast is good, the special tray will be good, and your bottom molding also will be a success. Okay. Well, you must have heard this famous saying: "For want of a shoe, the horse was lost. For want of a horse, the rider was lost. And for want of a rider, the battle was lost." So please don't lose in the battle because of one small thing that you can do to improve your primary impression. Now, this I am repeating is only for uh, if you're using alginate. Now, the one question that come to your mind is, what am I going to do if I'm using compound? For that matter, if I'm going to use putty, okay, putty also you can try this wax. As long as there is no heat, you can still use wax. But if you're using heat, because compound obviously is not a cool material, it is hot. Obviously, you can't use wax. Now, there are two possibilities. One is you will have to use self-cure acrylic resin, okay, and put it in the mouth and mold it. Now, that is not a very practical procedure. Please don't try that. It will not work. I mean, it's very difficult. Now, what you can do is, if you are doing the upper, for example, you load the impression material on the tray, right? Ask the person to half close the mouth, insert the tray in the mouth with the compound, right? And of course, and press it, obviously, upwards. But then move your finger backwards or posteriorly and tuck the impression compound in the distobuccal area into the distobuccal sulcus. I hope you understood what I said. You load the tray with your impression compound, right? Insert it into the patient's mouth, press it. So obviously the material will flow onto the impression, onto the ridge area, and in the distobuccal area. Now you have to do something. You move your forefinger to that side and tuck. I'm using the word tuck, like you tuck a bed sheet, or when a child is sleeping, you tuck the bed sheet. You tuck the compound into the distobuccal area with your fingers. I mean, both sides of this, right? With both hands, you can interchange your hands and tuck it inside. And and all this must be done when the patient is half open mouth. When the patient is the half open mouth condition. Patient is opening the mouth wide, it won't work. You will not be able to tuck it inside. Okay, and once that is tucked inside, tell the patient to move the jaw once or twice left and right, like you do for your bottom mold. That will make sure that your impression compound is really seated into the distobuccal area. This is something that many of us forget. We simply take the compound in the tray, keep it in the mouth, press it, and it comes out. Well, there are no creases, there is no fold, there is no deficiency, so everybody is happy. No, that does not mean your impression is good. You have to take care that you copy the distobuccal area also to whatever extent is possible in your primary impression. This is number one. Now you come to the posterior palatal seed area. I told you 99% of impression trays, lentulus trays, do not extend, or rather extend only about 3/4 of the hard palate. Right? 1/4 of the hard palate will not be covered by the tray. Okay, 3/4 itself would be a great thing. So, and what do we want in the primary impression? We want the entire hard palate, of course, goes without saying, plus a little bit of the soft palate as well. The soft palate also must be copied with your primary impression. If that is not copied in your primary impression, your special tray will not extend till the soft palate. And we all know that the posterior palatal seal area lies in the soft palate. And if your tray is not extending up to the soft palate, then how are you going to copy that area in your secondary impression? So, I'm repeating again, please don't think that whatever mistakes or errors you have made in your primary impression can be corrected at the secondary impression stage. I'm sorry, no. Marginal corrections you can make, a little under extension, all we can be able to manage. But major problems like underextended posterior palatal area or distobuccal area not copied entirely, these are not things which can be corrected during a secondary impression stage. And therefore, your primary impression is very important. Please pay a little more attention. I think great. Okay. So what do you do with the posterior palatal area? So if you look into your mouth, you press the compound onto the maxillary arch, and you can see something. In the posterior region, the compound will be seen to be slumping downwards. It will be as if it's falling off because there is no tray support. The tray is only 3/4. The rest of it is, there is no support. So the compound has no support, so it will flow down. You understood? So what do? You again insert your hand into the mouth and lift the compound or support the compound. Lift it up and press it against the hard palate and the soft palate. And hold it there till the compound becomes self-supporting. It's not enough to simply lift it and then take off your hand. Then again it is slump because the material is soft, no? So you should put your fingers and elevate it, and till the material reaches its becomes self-support. Now, in the case of alginate, of course, you can't do this. Therefore, you have to physically increase the length of the tray using wax. Now, how to do that? Well, I, I hope you will be able to do it yourself. Unless it is demonstrated, it's difficult to explain it. But in the case of the alginate, you have to use wax. Fold a sheet of wax, okay, and stick it to the posterior border, right? And one small little thing there: if you have extended the posterior border with wax, please make sure that you perforate that wax with a hot instrument. Otherwise, the alginate will not stick to that area; it will come off. Okay. Now, the question that I'm sure you will be asking, would like to ask, or I'll ask it myself and answer it now itself. Which tray should I use if I'm using alginate? It's very obvious. Perforated tray. Good. That's ideal. Yes. And perforated tray will have no problem. Alginate is meant for perforated trays are meant for using alginate. If somebody asks you why can't it be used for compound, I don't know whether the answer is not straightforward. Nothing wrong. You can use compound with the compound perforated trays. You can use for compound. Nothing wrong in that. Okay, but the opposite. Can we use a non-perforated tray for alginate? Because sometimes we do not have in our clinic non-perforated, perforated indigenous trays are not usually available. In many of I don't know about your personal clinics, but in many clinics nobody purchases that. People always purchase non-perforated trays, indigenous trays, and perforated indigenous trays. This is the standard purchasing method. So very rarely will you have perforated indigenous trays, right? So the question arises: how are you going to use a non-perforated indigenous tray to make alginate impression? Because there won't be any retention for the alginate, isn't it? Now, this is a small tip for you. You can do one thing. You can take this non-perforated tray, take a stick of green stick, melt it in the flame, okay, deposit a small blob of green stick on the tray. Let's say in the mid-palatal area, right? So it is still soft. Take a little ball of cotton and stick it onto this green stick. Because the green stick is still soft, the cotton will stick to it. You make this sort of small hills in multiple areas on the non-perforated tray, right? And then you can use alginate with that. These will act as retention points for your alginate. I mean, this is if you are using alginate, right? Okay, fine. This is also there are three things which you keep in mind. The tips actually. One is when you are making the upper impression, please extend the distobuccal area. If you are using alginate, with wax. If you are using compound, please make sure that you tuck the material into the distobuccal area. Then, if it posterior palatal area, in the case of alginate, extend it with wax. Don't forget to perforate the wax. If you're and the distobuccal area, the distolingual area, as you can see in the picture here, use wax to extend the border. If you're using alginate. If you're using compound, yes. In the case of the distobuccal area, upper, please tuck it inside. In the lower, I'm sorry, I forgot to tell you that. In the lower, if you're using compound, again, press the material into the mouth and with your finger physically push the distolingual area material in that region into the sulcus. And then, holding the tray down firmly, ask the person to just extend the tongue a little bit. That's doing a little molding. And that will give you the required result. Okay? So these are some of the things. And the bottom line is, the primary impression is as important as any other step. Because there are 5 steps, all these steps play a vital role. It's not that one step is inferior to another step. You mess up one step, the entire edifice, the entire building will collapse. So please pay a little attention to your primary impression, right? Now, what are the operator and chair position for this impression, which I am sure all of you do it. Of course, then the chair is set in the upright position. Headrest should be adjusted so the head and neck are in line with the trunk. See, you can see that picture there. The patient is upright and the head and the body are in one line. And you can see the head support compresses the occiput. This receiving is the occiput, not on the neck. If you compress on the neck, that can lead to sometimes can lead to a blackout, and definitely not figure B. That will be putting the patient under tremendous strain. As if you are bending the patient's neck downwards. So both these positions, which are marked with the crosses, should not be used. The one with the green tick is the right position. Where do you stand? This is the patient's position. Where do you stand? Now there is this first picture here where you can see the operator standing behind the patient. Now personally or from my experience or personally, this is not a good idea. Not at all a good idea. I don't know why this has come around, because once you stand behind the patient, you simply cannot do whatever I told you to do. Is it possible for you to insert your finger into the distal buccal area? Is it possible if you stand like this? I don't think so. Okay. So the ideal position for the upper impression would be in the 11 o'clock position. Okay. And the operator elbow should be 15 centimeters approximately above the waist for the upper impression. 15 centimeters above the waist. Patient's head should be positioned like that. Anything more than that, and you will have a lot of strain. Anything less than that, again you have to bend down for the upper. So that both are not good in the long run for your the health of your lower back, right? And therefore, this is so standing behind the patient is not a good idea. Well, if you're used to doing that, please do it, but think about whether you will be able to do the things that I told you to do. Whether you'll be able to tuck it inside, whether you'll be able to lift the material with your finger. Okay? Well, you can do it, but that will require a lot of circus-like positions on your part, which is not very nice, right? Therefore, I prefer that you stand in the 11 o'clock position for your upper impression. When you come to the lower, the 7 o'clock position would be nice. Okay, now whether to stand or sit, I would prefer that complete denture work is done in the standing up, or using stand-up dentistry, because otherwise the material can tend to flow into the throat. If you have a lying down position, right, it will flow into the throat, and that can cause gagging and all sorts of issues. So for complete denture, all procedures, not only this, standing up dentistry would be better. In this case, for the lower, the 7 o'clock position would be ideal for making the lower impression. Okay, right? So this is how you do this is your chair position. It's like this, and height. The height is, for the upper it was 15 centimeters above your elbow. You can raise it by maybe another 10 centimeters. Because otherwise again you will have to bend, you will be forced to bend down. Therefore raise it to another 10 centimeters and make the lower impression. Now impression materials. Now, I am not going to go into the details of all this. You know all the impression materials available, and you also know, and you being of the younger generation, will also know that maybe in another 5 years, these impression materials will all become history. They are becoming history, but definitely they will become history. And the Phillips textbook, which we all study or did not study, we don't know, right? I am sure the impression material will be restricted to maybe a couple of pages, because the digital techniques are coming into the field, the big way, the very big way, and impression materials will soon become history. 100% sure it will become history. When that is a question. That's something to we have to wait and see. But I'm sure for the next 5 years, impression materials will become history. But today, we still have to use an impression material, and these are the various materials available. You have arginate, impression compound. Then there is something called a combination. Now, what do you mean by a combination? I'll explain that in a minute. That's an important tip I'll give you. And then there is the putty wash. Actually, the putty wash is actually a combination technique. Now, alginate impression compound, I don't have to tell you more. Everybody uses it. Everybody knows how to use it. So that is that. Now, what is this combination slash putty wash? Now, I seriously suggest that you stick to the combination technique from now on. Now, what do you mean by a combination technique? Now, all of now all of us have experienced, especially if you're using compound. Alginate also the same problem, but many of us, since we don't use alginate regularly, let's stick to impression compound. Most of us know that when we make an impression with impression compound, rarely do we get a proper pakka impression in the first shot. There will be something will be there. Maybe a fold, maybe a deficiency, maybe underextension, things like that, over whatever. So what do? We repeat it. Again, we go back to the put it into hot water. Again, we mold it on the place it on the tray. Again, we place it in the mouth, press it, and then hoping for the best, we remove it. Aha! The fold that was there in the anterior is now shifted to the posterior. Oh, again, repeat. No, and I know all of us have suffered during our undergraduate days, and the teacher made us keep repeatedly asked us to make impression with impression compound till they get satisfactory results. Now, well, when you are a student, you don't have much of a choice. You simply have to listen to the teacher or the instructor because you can't argue with the instructor. So you keep doing it. Of course, that is part of the frustration of doing prostate, right? But now you're passed out. Now you are in the practical field. You're in the battlefield now, where you can make your own decisions, right? I'll tell you, give you a clue how to manage these folds and small folds, small deficiencies, right? Yes. Now, what is the problem? You are willing to try umpteen times, let's say 10 times. Give an exaggerated number. 10 times you are willing to put the compound, repeatedly keep on doing it. But then, please remember, there is a living protoplasm at the other end. That is the poor patient. You are softening impression compound at a temperature of, well, 60, 65, boiling water, God knows what's the temperature of the water we use. And you are repeatedly pressing the hot compound into the patient's mouth. Can you imagine the amount of discomfort and pain sometimes a patient is suffering? The patient definitely is suffering. There is no doubt about it. Okay. So the question is, do we really want to do that? Okay, it's a small fold, it's a small depression, okay, little underextension. You would correct it by repeatedly doing it. For what? To satisfy your ego. That I must get an impression with impression compound. Okay, fair enough. Then do it in one or two times, with one or two times. But that's not possible. You're not getting it. Alright, so let's shift to alginate. Now believe me, though we think that alginate is a nice, gentle, harmless material, so cool, right? And very comfortable for the patient, right? But there are two problems with alginate. One is this alginate is something which can deceive you. Please don't think that if you use you can easy to get a proper primary impression or vigilous compression with alginate. There will be defects. There will be air bubbles, right? And that's one thing. The second is the expense. Definitely, making primary impression with alginate is more expensive than using impression compound. All right. So while alginate is cool, very comfortable for the patient, it may not be that comfortable for you from an economical point of view. An impression compound is economic from the economic point of view, it's very good for you, but from the patient point of view, it is a torture. So let's combine them. Let's combine them. What's the problem? So you'll ask me, what do you mean combine them means what? Yes. So this is the way you do it. You make an impression. First, you take impression compound, put it in the mouth, and copy. Make an impression. Okay. Now you discover. Now if it's a perfect impression, fair enough. Go ahead, no problem. And there's no issue. But you see a small mistake here, a small fold, a little under extension, right? Or maybe a deficiency in the palatal area, right? Because compound may not have been enough because we are not astrologers, no, to predict the amount of compound exactly which you require. There will be mistakes, right? Now instead of repeating the compound impression again, simply mix maybe a scoop or a scoop and a half of alginate, load it onto this impression compound impression, and reseat it into the patient's mouth. In other words, the impression compound impression will become a tray, and onto that tray you are using alginate. Regular mixing. Don't try to make it thin and all that because that will lead to all sorts of issues. That will become too thin and then it will flow out, it will tear away from the compound impression. So use a regular mix, not too thick, not too thin. Normal alginate mixing. Consistency. Load it onto this impression, made with impression compound, reseat this whole thing into the patient's mouth, and wait for the alginate to harden. And believe me, you will get a beautiful impression. And all the mistakes which you have done there will be completely made up by the, will be covered up by the alginate. And another bonus thing about this type of impression making is, right, your secondary impression, your seal, the so-called posterior palatal seal or the seal, what we call peripheral seal, is 100% guaranteed. 100% guaranteed. You won't have any problems, right? Let us say your distobuccal border was not proper, you didn't mold it properly. The alginate will compensate for that. It will flow there. The alginate will flow, no, better than compound. So this is the combination method, right? I suggest that you try it next time you do adimation. It works. Now the putty wash is actually a common, the same thing, a more expensive version. You first make an impression with putty, right? And if there are any deficiencies, you load it with light bulb. But that is a more expensive proposition. So if you want to try that, that's up to you. You can do it. But this compound alginate combination is a very practical way of finishing your work quickly with excellent results. Right? So please, if you wish, you can try it out next time. Now, which there is one question whether should I make the upper first, the lower first. Well, that is your choice. Actually, I mean, you can argue both ways. For example, upper impression causes more discomfort and anxiety than the lower one because the material is going into the throat and the patient is keeping the mouth open, can't breathe through the mouth, so it's discomfort, suffocation, all sorts of feelings. Then and then the problem is after that, if you do the lower, and already the patient has suffered some sort of a discomfort. So when you do the lower, patient is totally out, right? And therefore, some people say let's make the lower first. But then the problem with the lower is there is a lot of salivation, okay, and that will cause overall increase in salivation, right? And ultimately, you will have to do the upper also. So that is your choice. Normally we teach our students to do the upper first. That's what you do, and all this discomfort is all just transitional. It's not a great thing, right? And of course, make sure that the person does not gag and all that. Otherwise, upper would be better. Okay? And of course, you will get the cast and all that. That's all understood. Now we come to, so once that is made, the impression is made, it is poured, saw the cast, right? And again, one small little tip: if you are using the putty, if you use the combination method, okay, please use stone to pour the cast, pour the impression. Sorry, to pour the impression. Because anyway, you have used alginate. Alginate will copy more details than compound. So why use plaster? Use stone. Well, again, there is no rule saying that you should use stone, but Since you have made a good impression with alginate or copied more details, use stone plaster, so whatever details you have copied there will be positively there. Plaster, as you know, is not that good at copying details. So that again is your choice, but I would say use stone for that. Yeah, okay, fine. So that is the so you got the cast. Now we come to the preparation of the special tray. We'll come to that, and the special tray is used for making the final impression. Right now, there is one question that arises here: what is the rationale? Why do we do it? I mean, what is the purpose of doing a final impression? Because I don't know. I have heard stories, and I wish they are not true. Maybe they are true. I don't know. That many practitioners, maybe because they are busy, or maybe they simply not bothered, they skip this final impression step. One primary impression is all that many people do, and they go on through the generations. The third step, they skip this final impression, and they are getting results. I am not saying that their dangers are failing; they are getting results too. So many of us many of you will have a doubt: do you really need to do it? Is it necessary? Plus, my the senior dentist under whom you are working, if you are working like that, is not doing it. And sometimes if you as a new graduate, fresh from college, insist that I must get a special tray, I must do bottom molding. The owner of the clinic or your senior there will say, "Do you really want to do it, doctor?" Then but we don't do it usually. Well, if you are very particular, carry on. I mean, okay, one time you say, second time you also feel, now, should I do it? The senior is not very keen on me doing it, so let's skip it. Now, that is a question which you have to pose to yourself. Why? What is the need for doing it? And one answer I can give you is for predictable retention. The predictable retention. It goes like this. If you do a denture and skipping the second step or second stage, right? The retention you get at the end is, whether you get it or not, is something that you have to leave to your luck, because you may get it, you may not get it, right? You cannot 100% say that my denture will be retentive. Well, you can say that, yeah, it will be retentive. No, it has to be retentive, right? But if you do your proper border molding, get your peripheral seal, in other words, do your second stage, you can be 150% sure that your denture will be retentive. Of course, barring any disaster that can come during the processing, but since the technicians, the labs do the processing usually, and they are experts at that, so they don't make any mistakes there, right? Barring that, it's a 0.1% chance. You can be 100% sure that your dangers will be retentive. Otherwise, well, may be retentive, right? And then you are always having a question mark in your mind. Will it or will it not be? So that is the answer for your question. Whether you produce a bottom molding or not, I think I am telling and requesting you that you must do that step. It may take an additional appointment, but you must do that step. Okay? And this is in retention. Now remember, the retention which I am talking about should be there when the person is at rest and when the person is functional. That's why I put the words here: functional retention, a functional retention. Functional retention means when the person is using it for eating, smiling, laughing, whatever, the danger should be retained. Also, when the patient is sitting quietly, the danger must be retained. So to ensure that we can predictably get this, please do the border molding. That is border molding, and of course the impression making also. Now the custom tray, I assume most of the new generations use acrylic because many colleges they don't encourage shellac. I don't know, but most colleges don't do it. So most of you are used to making acrylic special trays, right? Now regarding wax spacer, wax relief, this is all depending on the impression philosophy that you are using. But today there is only one accepted impression philosophy, that is the selective pressure. The other theories are not used for secondary, for making the secondary impression at least. Primary impression we use the mucocompressive one, but for secondary impression we use the mucoselective or mucoselective impression technique, which means you have to use a spacer. So the question is what type of spacer to use. Okay, now there are many institutions which teach the full coverage spacer. They teach the full coverage spacer, that is a spacer. I'm talking about the upper or lower, whatever. It is the upper, the entire hard pallet and the ridge is covered with a wax sheet, and you cut out 4 small windows in the approximately canine premolar region and in the molar region. Alright, and then you put acrylic over that and you get a tray where there is a good wax sheet underneath, attached to the tray. Right, and after doing the bottom molding, etc., you peel away the wax, leaving behind 4 small projections which are known as stops. You load the impression material, and that's it. That is standard procedure, right? So that is one type of special tray, full coverage. Spacer covers the full area. And there is another one which some colleges nowadays have started using, and that is the so-called T-spacer. As you can see here, this spacer covers only the incisive papilla, the rugae, and the mid-palatal traffic. Although today, according to that textbook Boucher, we should be covering the ridge also, not the maximum ridge. No, we don't want to go into those theoretical things now. Leave it there. The point is, this is the T spacer. Now the question is, which are you going to use? The full spacer or the T spacer? These are the 2 common spacers. There are so many other fancy designs which is actually which are arisen from the what shall I say, the fertile imagination of prosthodontists. But so we leave it there. We are not writing novels here. So let's stick to the practical considerations. So there are basically 2 types: the full coverage and this partial coverage, a T spacer. Now the answer to that question is we should be using this one. Now you will turn around, or the question can be asked, what is wrong with the other? What is wrong with the other? That there also I am getting results. I am getting the seal. Okay, I am getting a good impression, actually, beautiful impression, uniform thickness and all that. Right? Now the answer to that is this. If you use the full coverage, whether you use the full coverage or the T spacer, the seal, bottom molding, etc., it will have no influence on that. Whichever spacer you use, the obtaining the seal will have no bearing on the nature of your spacer. But then what is the problem here? The problem is like this. If you use the full spacer, we are not practicing what we are preaching. Okay? Now what is it that we are preaching? We are preaching that in the maxilla, there is something called a primary stress bearing area and a secondary stress bearing area. And as per our books, the primary stress bearing area is the hard palate. The ridge time being, just leave it aside for the time being. The hard palate. Okay, and we also say that this wax is called a spacer. It's given for relief. That's why I said close fitting tray with wax relief. Right? Now, we believe that the primary stress bearing areas should not be relieved. Only the secondary stress bearing area and certain more vulnerable areas we call as relief areas, incisive papilla and all that area stuff, they should be given relief. So wax spacers are given for relief. Okay, and therefore it should be given only on areas which require relief. and that is the secondary support areas. So, what is the logic? What is the justification for putting wax on the hard palate? This is the question. Because the hard palate is a primary stress bearing area where it should not be relieved. If you put a wax sheet there, it is relief. So here is a problem. Therefore, theoretically, from a support point of view, the T spacer is the better one, right? But if you want to ignore that, use the full spacer, no problem. As far as retention, etc., they don't make any difference. You will get retention. Bottom molding and all now doesn't influence that at all. But from the support point of view, what we preach and what we practice will be different if we use a full spacer. That's all, right? So this is keep this in mind. Now this is a tray, just a picture of the tray. As you can see, the handle is rectangular, not a shaped and all that fancy shapes. They keep it sweet and simple, right? Now we come to the bottom molding stage, and I am sure everybody knows how to do bottom molding. There is no doubt about it. All of you do it. I am sure you can do it. If you are not doing it, please do it. For reasons I have told earlier, that is, it's the shaping of the borders of the impression tray by using functional or manual manipulation of tissues. Okay, duplicates the contour and size of the vestibule. And why do we do bottom molding? Yes, that's the point. Why do we do bottom molding? The bottom molding is done to obtain what we call as retention for your denture. Denture retention is obtained at this stage. By doing a proper bottom molding, you should be able to get retention. In other words, the tray, when kept in the mouth, right, usually will not be retentive. But at the end of this procedure, it will develop the quality of retention for your denture. 1 minute now, 1 second. I want to do something. Yes. All right. Excuse me, I'll go a little ahead and then I'll come back because the tray I maybe a small mix up here. All right. So you made your tray. Good. Out of acrylic, the time being, with the T spacer. Now, before we start this bottom molding, you must check the tray for the following. One, retention. Now, please don't get me wrong. When I say retention, what I mean is you take the tray from the cast, place it in the maxilla, place it on the art, on the whichever upper or lower you are doing, and then you press it against the tissues and remove your hand. It should stay there. It should stay there. I'm not saying it will develop the retention in the at the end. That end retention is different. It should stay there. If you put the tray in the mouth, press it onto the tissues, you remove your hand, and the tray also falls down. Oh, there is a problem here. Something is wrong. So we have to do something about that. Then, okay, it is staying there. Fine. Now you should check for stability. Whether the tray is rocking. So how do you check that? You press on the ridge, the right and left ridge alternately with your 2 forefingers. 1 forefinger pressing on one side, see if the tray is leaving the other side. Change your finger of that, change it to the finger of the other hand, press on the ridge area, see if the tray is lifting off from the opposite side. If it is not, good. If it is rocking, that is a danger sign. Please change the tray. Right? Please change the tray, or maybe you have to change your primary impression. Now, that's what I said. If your primary impression is wrong, your tray will be wrong. If the tray is wrong, your impression will be wrong. If it is rocking, either the tray was made wrongly, maybe there was some distortion, or the cast itself has a problem. Right? So do what is necessary to find out where the mistake is. Then support, of course. If you put the tray in the mouth, you press it upwards. If it keeps moving or anything, maybe there is some flabby tissue, then you can do nothing about it. Other things have to be thought about that to find like, but essentially it support. And then of course extension. This is very, very important. Extension of the tray. Right? Now, then of course border smoothness. Once the everything has been collected, sandpaper the borders and make sure that there are no sharp edges. Now what is the extension? That requires a little expert. A little, okay, so this is what I have told now. Place tray in the mouth, observe whether it stays. Stability, place tray in the mouth, apply pressure on the ridge portion of the tray alternately. Observe whether the tray stays or whether it rocks. Extension, check whether the tray is at least 2 or 3 millimeters short of the functional sulcus, not anatomic sulcus. Functional sulcus means if you put the tray in the mouth, pull the cheek down, see if the tray is holding off. Okay, and reduce the tray. Still, when you pull the cheek, the tray is not falling off. So what's the problem here? Okay, fine, you do it, right? The problem is this: when you put such, for example, if you get a tray like this, you are adjusting it. If you put it back on the primary cast, sometimes you will see this appearance. So, like if you do it in college when you are a student, the teacher will come and say, "What is this? This is over trimmed. Over trimmed. You see, it looks over trimmed, isn't it?" But you know that you have checked it in the mouth, and this tray border is 2 or 3 millimeters shorter than the functional sulcus, not this sulcus which is seen in the diagnostic cast. The diagnostic cast sulcus will be much more deeper because of the impression material has pushed the sulcus upwards. So please don't put the tray back on the diagnostic cast and then take a look whether I have trimmed enough or not. Because you yourself will think, have I over trimmed it? No, you have not over trimmed it. You have correctly trimmed it. So this is a word of caution. Okay, so keep this in mind. Of course, the tray borders are smooth and round. Alright, so how to do the vertical border molding? There are two techniques, sectional technique and the one-step technique. Now, where do we start? I would suggest that you start with the disto-buccal border. Right? Ask patient to close the mouth and move the mandible to both sides. Remove tray and examine the border. Okay? The disto-buccal is the more difficult part, so do it in the beginning itself. Excuse me for just 1 minute. Just one minute. No, I'm sorry. So, ask the person to move the mandible to both sides, basically to mold the coronoid process. Right? That must be done. This is a sectional method. You do it in sections, disto-buccal, then move anteriorly on one side, go to the other side, then the postopalatal seal area and all that. Yes. Now, you have done that, and you have got a border. Now the question is it correct? How do I know it is correct? I'm looking at the border. How can I know it is correct? So what you look for is whether the border is smooth, round, inverted, not everted, with a dull appearance. Smooth, round, continuous, inverted, with a dull appearance. Okay? Now, in this context, allow me to go back a little bit. Yes. These are the types of borders. Smooth, round, continuous with a dull finish is correct. A sharp, thin border is underextended border. A smooth, round, continuous border with a shiny finish or glossy finish is overextended. A flattened border is again overextended. An irregular border shows lack of border molding. No molding has happened, right? So we should all aim to get smooth, round, continuous border. But one small caution, small tip here. Suppose you get a thin border, a thin border. So as per this rule, as per this classification, it is underestimated. But okay, so you add a little more material to it. Again, you do the molding. Still, it is remaining thin. Oh my God! Because we know that it should be smooth, round, and all that. No, it's not becoming simply round. It's a little sharpness there. Well, already I've added once. What you do is, please put this border molded tray, that tray back into the mouth and see whether the sulcus itself is shallow. If the functional sulcus is very thin or very short, very narrow, then please don't expect to get nice, beautiful round borders. Right? So even after doing once or twice, still you get the thin appearance, then please check again. Maybe the freedom is attached very close to the ridge, or where the mucosa, the buccal mucosa is attached very close to the ridge, the crest of the ridge because of resorption. In that case, please don't expect to get nice, beautiful round borders. So this is a word of caution. If there is any problem after repeatedly doing it, please check the surface. One step technique you can use. Of course, I think this is one technique that is nowadays done by many people using the putty. The putty technique. You make it in your rope, put it on the borders, and do the border molding in one step. Within 5 minutes, not even 5 minutes, within 2 3 minutes, it's over. So it's comfortable for the patient because there is no hot material. Green stick is hot. That's not there, and it's over in 5 minutes. Whereas if you do the sectional molding, it will take some time. Maybe that depends, half an hour, 45 minutes, like that. So now, so many people would prefer to do this one step technique. I have nothing against that. You can do it, absolutely no problem. But please make sure or ask yourself whether I am confident of doing the sectional border tracing technique correctly. Because one of the problems with this one step technique is you have to be extremely fast when you do the molding. Because you know that once you mix the catalyst, the base and the catalyst paste together, the polymerization starts for the rubber base material. And if you don't mold it quickly from one side to the one end to the other, then by the time you reach the opposite, the other side, the material has already become slightly polymerized and hard. Therefore, your fingers must work quite fast, right? The molding must be done very quickly. Okay. The second problem is if if you don't do this molding correctly. Suppose you don't. That is the usual molding technique is outward, downward, inward. This is the usual procedure for the upper, right? Suppose that you are not doing it really correctly, then the material is very, there's a great chance that the border will become overextended, right? So, but with green stick, you can correct it. If you okay, you think it is overextended, okay, you flame it again and repeat it. For this one, you will have to cut away that entire half, right? Again, put new fresh material and do it again, which means, well, makes it more expensive and well, more frustrating also. So, unless if you're very sure that you can do with your green stick material fairly fast and fairly accurately, It's better that you defer using this technique until such time. Right? You can try it, but keep these problems in mind. Don't think that this you can do like with this. It's very easy, so I'll do it. But then you're liable to get an overextended. Yeah, of course. This is the molding material. The one step you can see, one shot, everything is kept together. Then we have already said all this. Yes. So the bottom molding. Okay. Uh, so the technique is you put your BM material, bottom molding material on the tray border, and for the upper it is outward, downward, inward. 2 times. Outward, downward, inward. That's all. Never do the Koyamb technique. Don't apply Ayurvedic liniment on the cheek because there is a technique like that. You put the green stick the material on the border and then you pull, you do like this as if you are massaging the cheek. Please don't do that. That is liable to lead to an overextended image. Okay, this is another what shall I say, word of warning. Now, all right, you have finished your water molding. You have put your posture panels. Everything is ready. Now, how will you know this correct or okay? You can tell me okay because sir, it is over. It is dull finishes there. There is a smooth, round, continuous border. Okay. Fine. But with the naked, those are all guidelines. But in the real world, it is a bit difficult to make out the dull finish and all that. Not that practical. Theoretically, yes, you can say that. So you must be able to know whether the extension of your bottom is correct and whether the seal that is developed is also okay. Now, when I say also okay, I will explain it in a few minutes. So, how do you evaluate all this? Because if somebody asks you, you must have faced this question: which is more important, extension or retention? The answer the examiner expects from you, or rather, they expected from you was extension. Because if the border is correctly extended, you will get retention, right? Whereas if the border is not correctly extended, you will not get retention. It's as simple as that. Then you will ask me, okay, so what's the meaning of this question? I mean, that is understood. I mean, why are we asking this question at all? Because the border is correct, extension is correct, retention is correct. Then why are we raising this question? Yes, that's a valid point. The reason is this: an overextended impression will also give you retention. That's the irony. Underextended impression, okay, you may not get your retention. Fine, that's understandable. But an overextended impression will also give you retention. A correctly extended bottom molding I mean, will also give you retention. And so, fine, so good. That's nice. Whether it's overextended or correctly extended doesn't make any difference. Then why are we saying the glossy finish is not good? The reason is this: an overextended impression will give you retention when the person is passive. The minute the person uses the denture for speaking or eating or smiling or whatever, the denture will fall. This is the problem. So, a overextended impression will not give you functional retention. A correctly extended impression border will give you functional and a functional impression. Whereas the other fellow will give you only impression when the person is sitting quietly. Oh, that's a problem. But retention will be there if the person is sitting quietly. The minute the person opens the mouth, the denture will fall. So you need to know whether the retention you have got is because of correct extension or over extension. So how do we do that? It's not a big thing. You can try it. Why evaluate? I already told you. Now, why do you evaluate? Now, how do you do that? Very simple. You place the bottom molded retentive tray into the patient's mouth. Ask the patient to perform some functional movements. For example, open and close the mouth 3 times as wide as they can and observe whether the tray is displaced. If it is displaced, somewhere there is a problem. Right? We have to identify that in mold technique. Second is, ask the patient to move the lower jaw side to side about 3 times and observe whether the tray is displaced. That's to check the stomachache extension. If it is displaced, we have to remold it again. Okay? Then manipulate the cheek, and if it is lower, the tongue outward, downward, and inward, and observe whether the tray is displaced. This will do the bottom molding for the whatever procedure you do for the bottom molding. For the lower also you try for the lower, and the upper same thing. Pull the cheek outward, downward, inward. See if the tray is displaced. Okay. But there is one small tip here. That is, for the lower there's a small difference, because however wonderfully you have done the lower lingual bottom molding, no bottom molded tray, lower tray will stay in the mouth if the person pushes the tongue out completely. If the person extends the tongue out completely, then any bottom molded tray will be lifted up. It will come up. So then how do we assess? To do it like this. Place the bottom molded lower tray in the patient's mouth. Ask the person to open the mouth half open. Lift the tongue, and with the tip of the tongue touch the upper lip. Ask the person to lift the tongue and touch the upper lip. Okay, see if the tray is lifting. If it is not lifting, ask the person to wipe the lip, upper lip from corner to corner with the tip of the tongue. See if the lower tray is staying there mostly, meaning slight movement is there, but that's okay. Okay, so this is a way to check for the extension of the lower, lingual extension of the lower. So if it clears all these tests, the borders are smooth, round, the matte finish, there is anterior seal, osteopalatal seal, then and then only proceed with the impression. So do your border molding correctly, visually examine the border, see if there is a smooth, gloss, smooth, shine, matte finished, continuous border, and you can check for seal. Once the seal is obtained, okay, chill the tray in water, place it back into the mouth, and submit the things to those tests I just told you. Open and close the mouth 3 times, move the jaw side to side, pull the cheek and lips down, right, and see whether the tray is seated. If it is falling off, somewhere there is an overextension. So identify that area, flame it, mold it again, and it can be done. Good. And once you are absolutely sure that the impression is going to stay there for functional and non-functional situations, don't make the impression. Okay. So mandibular is the same story. You can do all that. Okay. Now, yes. So the impression is over. The secondary impression is over. Whether you do beading and boxing and all that, that is up to you. In private practice, I don't think there will be time or time. I don't know whether you can do it. Maybe if you have an assistant or something, maybe you will do it. But I suggest that you do it. If whenever possible, try to do the beading and boxing, because that will give you the sulcus will be protected. But I am leaving that to your judgment. Now that is ready. The master cast is ready. Then the next step is to make the temporary denture base, wax a puzzle rim on that, and proceed to the next step which is perhaps the biggest problem for most of us. Jaw relations. Jaw relations are perhaps the biggest stumbling block in our difficult. If somebody were to ask you which is the most difficult step in complete denture making, it is jaw relation. Okay, and I agree with you that it is indeed not a simple thing. There are some problems with this, but again, we will see how to make it as painless as possible. It's not going to be 100% painless for you. We'll try to reduce the pain. Now, what are they? Any spatial relationship of the maxilla to the mandible? Any one of the infinite relationships of the mandible to the maxilla? Well, as jaw relations or maxillomandibular relation is relationship of the mandible to the maxilla. Why do it? Ah, why do it? It's mandatory because if systematically done, it results in a set of dentures that patients can use comfortably in terms of optimal stability and retention. This comfort translates into a hassle-free practice, right? Now, if you don't do this step properly, right, you will make a denture very uncomfortable for the patient. They cannot use it for mastication, right? And such a denture will actually lose stability and retention. Yes, believe me, if your jaw relations go wrong, you don't do it correctly, right? You will end up with a denture that loses its retention on it. Now you'll ask me how that is possible. Yes, it is possible. If you don't do it correctly, your denture will be a big failure, right? So that's how important it is. Now, as you know, there are these steps: orientation, jaw relation. You all studied in college: orientation relation, vertical relation, horizontal relation. Now, to be very frank with you, orientation relation is not a maxillomandibular relation. That is somehow it has got into this list. Orientation relation is actually relating the maxilla or whatever to the skull. That's not a maxillomandibular relation. Time being, let it be there, and we are not going into that. And just this is that wonderful instrument we use for doing this particular step. You have seen this. You have seen this picture in colleges. They must have come to the class and showed you this instrument called the face bow. Hmm. Frankly speaking, this is the useless piece of equipment. It doesn't give you anything. No, no, we are not going into the controversies regarding this instrument. But I'm just telling you that this is not a very use. It's not very. It doesn't make any difference whether you use it or not. But still, this is the instrument, Facebook, for orientation relation. Since we don't do it routinely, we are not going into the details of how to do it. That's all you have to do. Yes, yes. So how do you start this business? How do you start doing the jaw relation? I don't know what is it that what is that you have been taught in your various colleges, because you all come from different backgrounds. But I would suggest that you follow this, what I'm going to tell you, and well, you can compare it with what you have learned and see which is better. Take the decision you can take. The upper and lower record blocks are preferably made of self-cure acrylic, is what I think everybody does these days, after blocking out undercuts with wax. The occlusal rims are made to standard specifications. We're not going into the specifications, you all know that. Of course, this is a record base, the upper and lower record base, and this is a completed. I hope you know the name of this particular thing. We usually call it as occlusal rim, which is not fully correct. Occlusal rim is the wax part, and the wax part gets attached to the denture base, temporary denture base. The entire unit that you see here is called a record block. Called a record block. Okay, but we use the word occlusal rim. What we mean by that is this. But strictly speaking, what you see on the screen now is called a record block. It doesn't matter. I just informed you that there is a name for this. Now what do you start with? How do you start the work? Fine. Step number one. You take this record block, which comes from the lab, or you have made it yourself. I don't know. Put it on a glass plate. A glass plate is mandatory for this work. And see whether the occlusal rim the wax part is absolutely flat on the rim, on the glass plate. You just put it on the glass plate and see whether it is rocking, whether there's any gap. Okay. Now, if it is not flat, now one question will be there in your mind: why should it be flat? Why should it be flat? That is a question we'll answer later. But the other question is, suppose it is not flat, what can I do? The usual way what you will do is, you will take your hot plate, heat it over the flame, put it on the put the glass puzzle rim on that, and melt it off, and then put it back on the glass plate and see. Yeah, that you can do that, but one small thing you can do: you melt the wax with the hot plate, opposite surface, put it on the glass plate and press it nicely. Nicely press it, firmly press it. Show it under running water and slide it off from the glass plate. Don't pull it off. Right? This is the best method to make your opposite rim flat. Absolutely flat. This is mandatory. Make it. Okay. Now it's ready. Now you have to adjust it. What are the adjustments? There are two parts: adjustment for aesthetics, adjustment for function. Okay. So what are the adjustments for aesthetics? Fullness, lip fullness or lip support, visibility, midline, and the plates. Okay. So when we say lip fullness is, when I put the rim in the mouth, the lips should be adequately supported. Right? When the person smiles, there should be adequate exposure of the labial rim. And the midline should be marked in this step, this stage. And then of course the two plates, the anterior plate and the posterior. So how do you assess lip support? Put the rim in the mouth, observe the patient in profile. Look from the side. Right? If you look from the side, what should you look for? Three things. One is the nasolabial angle. That should be roughly 90 degrees. The nasolabial fold should be kept undisturbed, and there should be adequate eversion of the vermilion border. When a person becomes edentulous, when they close their mouth, the upper lip collapses inside. When your rim is in the mouth, the vermilion border should be everted. These are the three guidelines for determining whether adequate lip support is there. If the nasolabial angle is acute, it is over supported. If it is obtuse, it is under supported. If the nasolabial fold is stretched out, it is over supported. If the vermilion border is not everted, it is under supported. Now visibility. So next is visibility. How do you check? There are two types of visibilities. Inside the patient, is it upright and with the record block in place, and ask the part the lips slightly. Only 1 millimeter or maximum 2 millimeters of the occlusal rim should be visible. Then ask the person to smile broadly, so the lip will climb up. Please mark that position of the lip. And the first step number 1, ask the person to close the mouth. Just mark the lips, right? Mark a line 1 millimeter for older patients, 2 millimeters for less older patients, below the lip. When you have two lines, one is called the lower lip line, the other is called the high lip line, right? And the distance between those two lines should be the length of your central incisor. Then you will get adequate aesthetics. Because if there is no visibility, if the person parts the lips, then what is the problem? The person will look as if he's still edentulous, right? So it is very important to have these two types of visibility. So see, this is the before adjustment, so much of visibility is there. After adjustment, you can see just enough wax, right? Now, the midline should be marked now. I am repeating again. Please mark the midline now, not as an afterthought after finishing the sealing Oh, I forgot to draw the midline. Okay, here it is. No, there's a reason for that. Okay, there is a reason for drawing it now. But we'll talk, next time we'll talk about that. But please mark the midline now. Okay, so how do you mark the midline? Seat the patient upright, use freedom or whatever technique you want to use. Use the freedom, use the middle of the face, whatever, and mark it using a sharp instrument. Now, the question is, how do you know it's correct? Because you are standing by the side of the patient. You are twisting your body and marking the midline. So to do that, you draw the midline using whatever technique you want. But ask the person to step out from the chair, stand in front of you and smile. And see whether the midline you have drawn is in the middle of the face. And you will clearly be able to make out whether it is shifted to the right, left, whether it is slanting, etc. This must be done. If the person is a little old, then getting out of the chair, etc., will be difficult. So you can tell the person to sit upright, put the legs down, and sit facing you sideways. Right? So that's how you, but that must be done. The midline, mark the axle. Then the two planes, anterior and posterior. The instrument, as you know, you use is a Fox plane. Everybody knows about the Fox plane. The anterior part of the plane should be parallel to the interpupillary axis, and the posterior part of the plane should be parallel to the alar triangle line. Now, yes, now alar triangle line. I don't know how you can see this picture here that this person is using a scale. Now, sorry, please don't use this technique, the scale technique. That can make you commit mistakes. What you can do is you can take a thread, coat it with dry plaster, not wet plaster, dry plaster, hold it on the face, on the superior border of the trigger, to the inferior border of the end of the nose, press it on the skin lightly and take it off. It will leave a small thin line there on the face. Why you are doing that is because then you can concentrate on your Fox plane, holding the Fox plane. Otherwise, if you look at this picture, that person is one hand is holding the scale, another hand is holding the Fox plane, so that makes it a bit cumbersome. So please do this. Don't put the skin in wet plaster, with that you will look at patients got whitewashed afterwards. Just dry plaster, coat it, okay? And draw the line and check. Now, adjustments for function, vertical relation and horizontal relation. Why do it? Vertical relations, because if the height is more, the person will look, the lower one, the middle one third, the lower one third will look stretched. The lips are stretched. That's unaesthetic actually. Then the teeth will keep each other, etc., etc., etc. So aesthetically there is a problem. Functionally also there is a problem. If it is the freeway space is more, then again aesthetically there will be a problem. Collapse lower jaw, lower third, and also angulation. The angle of the lips they become more prominent, and angular cheilitis, etc. Right? And now that these are all okay. This is all standard things. But there's one more thing that will go wrong if your vertical dimension is not correct. And that is the centric relation will go wrong. I hope you understand what I said. I'll explain briefly later on. But if vertical, because vertical relation and horizontal relations, okay, that is relation of the lower jaw to the upper jaw in the vertical plane, and relation of the lower jaw to the upper jaw in the horizontal plane. This is what we mean by vertical and horizontal relations. If the vertical relation is wrong, the horizontal relation also will be wrong. Right? So keep this in mind. They are not separate in that way, they are interconnected. Right? Now, this is a technique I am sure all of us use. This one was technique. Ask the person to, and the first, and you measure the VDR first, and vertical dimension rest, vertical dimension occlusion, and the difference should be 3 or 4 mm, not between 2 and 4. No, that's not the correct way. Either it should be 3 or maximum 4. Okay, so be very clear. 2 numbers. That's all. Procedure: the cord block are put in the mouth, ask the person to relax. The three ways of doing it: you ask the person to say M repeatedly, or whatever technique you use, Ram or M, Mummy, whatever. Then that doesn't work, ask the person to wipe the upper and lower lip with the tongue, swallow, and sit quietly. Or like a pranayama, ask the person to inhale and exhale 2-3 times, sit quietly, looking straight. Right? And of course you will put one dot on the nose, one dot on the chin, right? And then when you feel that the person is at rest with the lips in light contact, the lips should not be parted, it should be light contact. And when you think that the person is sitting at rest, measure the distance between these two points with the upper rib in the mouth. Okay, and then put the lower rib in the mouth. Ask the person to close the mouth, please. This is important. Don't ask the person to bite. If you ask a person to bite, many of them will bite to the front, or they will bite on their preferred side, both of which we don't want. So tell the person, please close the mouth. Just close the mouth. Okay? Now the lips also will close automatically. Measure the distance. That is video. The difference must be 3 or 4. If it is only 2, take out the lower, reduce the height again, remove the wax, and get 3 or 4 difference. Alright. Now, this is the Niswongas method. But you know, Niswongas method is one of the better methods in the list of methods that is given for measuring vertical dimension. Because the rest of the other methods are absolutely 100% useless methods. None of them are practical. Right? The only method that works somewhat is Niswongas method. But Niswongas method has also got so many drawbacks. So one method I'll tell you is, you put the upper in the mouth, put the lower in the mouth, ask the person to close the mouth. Okay? Now the lips also will be touching each other. Look at the mentalis muscle, that is the chin region. If you see puckering there, I hope you know what is meant by puckering. I hope I am audible. Hello? Hello? Can you hear me?
Yes, sir, we can hear you, sir.
Hello, can you hear me?
Yes, sir.
Oh, okay, fine. All right. So you look for puckering. That is, this portion becomes constricted. That means the height is more. It's an easy way of finding out if the height is more. Right? Measurement, if you want, you do it. But if this is puckering, if it's puckered, please reduce the lower, and that thereby you can adjust the height. Now, why do it? Why do the horizontal? Why do the horizontal relations? Sorry for the slide. Because horizontal relations are going to give you what is known as centric relation. Centric relation is the most important horizontal relation. Okay? The lateral relations are not done routinely, and if you do those things, you need special equipment for doing it, which normally we don't have it, and basically it is useless. So leave it. We are not going into that. So the only relationship which is important is the retrusive actually, not even the protrusive. That is the centric relation. Why record centric? Because it is a jaw relation where the condyle is in the most posterior region in the fossa, right? And it's supposed to be the most comfortable position for a condyle to be. Okay, and it's a reproducible, stable, and comfortable position. All right, and once the condyle is there, we develop a occlusion which will be in harmony with that position, and then the person can function with the dentures more comfortably. There are controversies, there are problems with what I am telling you, but we're not interested in the controversies or the problems with this particular saying. But right now, just keep it like this. Don't want to go into the controversies. Okay. Now, how do you do it? Stabilize the upper block, with the ginger adhesive if necessary. Just the lower block is already ready, the height is adjusted. Stand in front of the patient, stabilize the lower record block with the forefinger. See, this is the way to do it. Put your forefinger inside, stabilize the lower with your on the buccal sheath area with your two forefingers, the two thumbs. One thumb you can see under the chin, because then the lower record block will be completely under your control. Please don't try the chin position or the chin pushing technique. Please don't do that. That's an absolutely wrong technique. I don't mind, I don't want to mince words, but there are people who do that, and I'm very sorry to say that is absolutely the wrong way of doing this particular step. You will end up in a lot of trouble, right? And so this is the best technique to do. Two forefingers on either buccal flanges, two thumbs on the thumb on the chin. Stabilize the lower denticles. Okay. Okay, and then what do? I'm not going to read all this, I just tell you what it is. You ask the person, now what do you do now? There are two things. People say, roll the tongue back and close the mouth or bite. That is one technique, right? But there's a small problem with this technique. Suppose the person has got a tongue tie. How is the person going to move that roll the tongue back? Person cannot. Now you get frustrated. So best thing is, stabilize it like that, right? Then ask the person to open the mouth, relaxed, not wide opening, just relaxed opening. Okay, 3/4 opening. Then ask the person to just close the mouth. Just tell the person to close the mouth. So they will close the mouth. And when the person is in the process of closing the mouth, you gently give a posterior, guide. You guide the mandible backwards. Now, please remember, this mouth, the patient is very essential that the patient opens the mouth in a very relaxed manner, not in a strained manner. You repeatedly tell the patient, don't open too wide. Okay? Close and ask the person to close the mouth, not bite. This is very important. Okay. Now, repeatedly ask the patient to perform the closure and confirm CR by drawing guidelines on the ribs. How you know it is correct? So once the person takes the jaw back and closes, take a carver and draw two lines connecting the upper and lower ribs on both sides. Repeatedly do it to ensure that the lines are coinciding. To make it sure that the centric is repeatedly done correctly. But this is not enough. This is the easy part. The more little bit tiresome part is to ensure that when this contact is made between the two rims in this centrifugalation position, the contact is both bilateral and it is simultaneous. That is, both right and left must meet evenly and uniformly together. Not that one side touching first, then followed by the other side. No, that's not correct, right? So you have to make sure that both sides touch evenly. Once bilateral contact is established, you can seal it, select the teeth, and discharge the patient. The selection of the teeth. Now that is something which is completely, let's say it's 80% in the hands of the patient. 20% you can make your choice, you can make your suggestions, but please listen to the patient's requirements and do accordingly. The patient says, I want the white teeth when the person is a little dark. Don't bring in your Fresh and Fisher articles or your textbook and tell them that no, the textbook is saying it's not like that. That simply doesn't work. You simply follow the patient's instructions to the, within reasonable limits. If it goes beyond that, you tell the patient these are the problems that you will have if I give you very white teeth. For your age, this whiteness will not be good. But patient says, no, I want white teeth. Okay, give it. Because ultimately the person is the person who's going to wear it, not you. So listen to the patient. Right? Size. Patient says, I want small teeth. Patient's face is big. You know, if you give that, there's going to be a problem. So tell the patient, see, this is the problem. And if you insist, I'll give you. And you can see for yourself in the mirror afterwards. Right? So please listen to the patient for selection of the teeth. 20% you can suggest, 80% is patient's visit. Good or bad is not you to judge. After that, we articulate. I've shown these three pictures are there. One is the the least expensive one. The second one is a more costlier version. It's about 1.5 lakhs now. And the other one is an even more costlier version, right? I don't know the cost. It runs into 2.5 or 3 lakhs. But we don't want to go into the again controversies in this because both are equally useless or equally good. That's all. I'll just say that much and leave it there. Right? Both are equally good or equally bad. They don't have any superiority over the other except for the cost. Now this is what today they do called virtual articulators on a computer screen. That is the newer version. But I'll show you something. This is called the bio. This is just for your information. Bionic jaw motion analyzer. You see this picture? This is actually a articulator. Not in the sense it's an articulator. It's a simulator, right? It will do the move. It's a robot actually. It will move according to your patient's movements. No need for Facebook. No need for anything. And this is what we are now having today. I mean, not commercially, but experimentally at least. So things are changing. These people will soon go out of business in the coming years if this becomes very popular. Okay. Now, the next stage is the trial stage. Now, I don't know how. That's what I said. I do seriously wish I could be in front of you, talking to you physically. But I wanted to ask this question to you. How much time does anyone take for doing this step? If the answer is 15 minutes, well, I'm sorry, that's not the way this step should be done. This is a very, very important step. And for some reason, we don't want to spend too much time here for whatever reason. Why? The reason why we have to spend some time is this is a stage where you are going to check whether the fit, the aesthetics, the mandibular maxillary relations, the phonetics is all okay for the patient, right? And this is perhaps the last chance you will get to correct any problem in your jaw relation or teeth selection or teeth arrangement, right? If you miss something here, the mistake will be there in your final denture. And if the final denture was a mistake, correcting that would mean repeating everything from the beginning. So please don't treat it as a, well, just adjust a step which you can just casually do it. It's not like that. And to help you to do that, you need to prepare a checklist. A check. That is because otherwise you'll forget what all you're supposed to do. Okay? And also, if possible, get an informed consent from the patient. Otherwise, tomorrow the patient will come and say, I didn't see the danger, I didn't know what happened, doctor gave me something. Okay? No, that's not, patients to justify their position, they will say so many things if they are unhappy. But that is for your own safety. Okay? Right. So the checklist has to prepare. Now, this step is important because the last chance to correct mistakes, barring any other than retention. Of course, retention you can't check now. That is already checked. But if everything else, your relation, teeth selection, phonetics, right? All those things can be checked now. And if there is a mistake, don't hesitate to repeat the jaw relation. That's it, simple. It's difficult, I know. But that's the best way to do it. Otherwise, the end product you will suffer. And this step is called trial. Some people call it try-in, but the more descriptive word would be verification. We are verifying what we did during jaw relation, during teeth selection, during teeth arrangement are all come okay or not. Okay, so we are checking for jaw relation, aesthetics, phonetics, and last but not the least, patient's approval or appraisal. That's very important. And for aesthetics, you check for the label fullness is adequate, the visibility is adequate, midline is adequate, the planes are adequate, then whether the teeth you have selected, their size, shape, color, arrangement, smile line, buccal corridor, all those things are come together nicely, right? I hope you know what is smile line, buccal corridor, the dark space when you smile between the cheek and the teeth. called the buccal corridor that should be there. Then of course you can verify that the vertical relation is correct once more, whether the centric relation is correct, whether there is bilateral simultaneous contact in centric relation, in CR. All those things you should verify now. And you should prepare a list of all this, and as you go along you can tick or cross depending on whether it has come out correctly or not. Maybe after one or two times this will become a habit for you, so there's no need to write it down. But initially it would be better to prepare a checklist. Okay, and in fact a printed checklist, and you can keep it and save it as a record. So tomorrow, if you have a doubt later on, did I check that? Yes, I checked. It's a record of your checking. Then phonetics, F, B, S, and then the last but not least, give the mirror to the patient. And then what do? You give the mirror to the patient, and what are you supposed? Where are you? What should you do then? Please move away from the patient. Give the mirror to the patient and move away from the patient. Go outside. Go to your reception. Go somewhere else for 5 minutes. Let the patient, if there's a bystander. Let the patient, the bystander, and the mirror be with themselves for a few minutes alone without your presence. Okay? And then you return after 5 minutes, and where will you stand? You should stand behind the patient and observe the patient in the mirror. And both of you should be looking into the mirror. And then you ask the patient, do you have any suggestions, any complaints, or any changes you want to make? And you will ask, why do you want to go behind the mirror? Only if you stand with the patient and look into the mirror, you will appreciate what the patient is telling you. Otherwise, it will be from your point of view, which is not the patient's point of view. It's called the reverse mirror technique. Okay, so that's where you stand for that signature. And if patient is happy, please take an informed consent. And once that is over, you can go in for the insertion. And insertion, at the time of insertion, please give printed instructions, not verbal instructions. They will forget. Right? Now, at the time of insertion, treat the denture as a product. You have manufactured a product. Now you are going to sell it. Right? I know it's a bit cold-blooded thinking, but it is a product. And when you sell a product, there are some things that any salesman will do when they sell you any instrument or any device. They will adopt the following technique. They will tell you how to use the appliance. Then they will tell you there are some problems, common problems, which you can solve yourself. And then how to take care of the appliance. And they will tell you that if you can't solve those problems, please come back. And then how to take care of the appliance. Same thing we will do with the denture. First, you tell the person how to use the denture. Second, you tell the person, okay, there will be a few problems, you can take care of them. Beyond that, please come. Right? And third is, how do you take care of the denture? How do you keep it clean? How do you store it? So such things. So say you can use this analogy when you deliver your denture. And so it's like this. Every new denture is like a new shoe. It has some time and care to adjust. Don't eat hard or sticky food. Never bite with the front teeth. Chew in up and down movement, preferably in the polar premolar area. Drink fluid in sips, not in large gulps. Then 6 to 8 weeks usually will be there for accommodating, learning to chew with new dentures. The next salivation will be there, but that will come down, right? The eating habits, don't use sticky foods, hard foods, tough foods initially. Chewing should be up and down, no biting with the front teeth. Use a handkerchief when you're coughing. Use a handkerchief, otherwise it can become a little embarrassing if it comes out the lower denture especially. Then speaking and salivation are two of the issues that patients can face. Tell the person speaking will be corrected in a week or 10 days time, and salivation will reduce after a few days. Ask patient to read loudly from a newspaper for 10 to 15 minutes. Reassure patients that salivation will subside and desist from spitting their excess saliva. Right? Clean after every meal, taking care. Never wear dentures during sleep. Clean with soap, toothpaste, store in normal water. Never wash denture with warm or hot water. Then of course you can ask for handles, clean the denture, place the cleanser 30 minutes, maybe twice a week. Right? The standard procedures, right? And they should not be worn at night. And then the person should return at least a week after use of the dentures, whether the patient likes it, whether has any issues or not. Call the patient, tell them you come here. Even if you have no problems, please come. Now, so I know this is a very long discussion, but actually very difficult. You know, the company that they are making, I mean, you know that we have touched only here, not fully, but it's enough, I hope. Okay, so I hope you have got some idea about the difficulties and some tips which I promised I'll give you. Uh, so to sum up, one important tip is, if possible, shift to the dual impression technique. Okay, then check the border molding of your tray using those 3 tests, right? And for jaw relations, please make sure that the height is corrected by looking for puckering, and make sure that there is bilateral contact on both sides simultaneously, right? And for trying, please prepare a checklist and devote some time for doing it. Right? And then the usual denture instructions, which preferably you can give it as a printed form. So, thank you for your attention, and it's late. I hope I managed to tell you something. So, I don't know whether there is time. Yeah, I have no problems. If there is anybody who wishes to ask me, you can ask. I have not touched patient complaints, I know. Patient complaints are, that's what I said. It's not complete actually. Patient complaints is there, that's another area. So, if you have any specific problems, you can ask me. I'll try to answer. So thank you once again for giving me an opportunity to interact with you, although virtually. I can't see your faces, but I hope you can hear my voice. So thank you. So any questions you want to ask, you are free to ask.
Thank you, doctor. Thank you for this presentation. It was well explained and very detailed so that we could understand. There are few questions which are being put forward by the participants.
Yeah.
One of the question is that how to select shade of the tooth for
Ah,
edentulous patients.
ah. Okay. How to select the shade of the teeth for complete dentures? So that's a very tricky question. Mhm. Because because there is actually no single technique for doing that. If you understood, and it's pretty difficult, because if it is a crown or a bridge or something like that, at least you have an adjacent tooth to match your color or match your shape. In complete dentures, there is nothing. It's an empty space, and you are supposed to get one tooth there. Now, usually we try to match the color of your tooth or shade. I should not use the word color, with the skin of the face. That's not a perfect technique, but that's the only way you can do it. Match the skin of the face, color of the skin of the face to your teeth. But as you must have studied your SPA concept, sex personality age concept, which says that if you are an older person, you are supposed to select yellowish teeth. Younger patients will be whiter. Now, I told you, that's why I told you there itself. This is the textbook. In real life, you have to follow the patient's likes and dislikes. You understood? If the purpose, I'm not. This is not me telling you. If you read Boucher, that's a textbook, you will be surprised in that part where he talks about the trying part, no shade selection for teeth, or not trying. Uh, you will be surprised that he very clearly says in every other paragraph that leave it to the patient. I was surprised actually when I read that. I don't know if you're going to leave it. So he keeps on saying in various aspects, leave it to the patient. Patient's decision is final. And which is maybe, if I think about it, that is correct. So, well, if you want to do it, match it with the skin color of the face. Alright? And then, if the person agrees to your suggestions that as you grow older, you become little, your teeth become little yellowish, so that will be better for your age. If the person accepts that, do it. Otherwise, if a person is 70 years old and wants white teeth, you give white teeth. That's all. That is because there's no point in arguing there because you don't have any logic for that. You understand? The patient's wish, follow it. That's all. But skin color of the face would be a good idea. That's all. Nothing else. And now wait 1 minute. Now I am surprised because now we have artificial intelligence and all that, right? So I'm sure it has not come so far. I think the artificial intelligence can be used to get the best color for your patient. I mean, in fact, now I think there's facial scans. You can change the color of the teeth and show the patient how each color will look on your face. If that technology is available with you, or you can buy that program, I think. Then it will be easier. You can scan the patient's face, put it on the screen, and use different shades of teeth and show the patient. If I use this shade, this is how it will be. If I use this shade, this is how it will be. And artificial intelligence can be used to predict the correct shade for the patient. And that can be shown to the patient. But that's all possible today. But otherwise, good old mechanical method is crude actually, which you can use. But patient wishes are paramount. That's the point. I don't know if I have answered your question. Hope so. So, what is the second question?
Yeah, doctor, thank you. And the other question is how to select the shape of the tooth.
How to select the
Shape of the teeth.
shape of the teeth? Yes. Ah, that usually again you have heard of this textbook knowledge, Bjorn Williams, square tapering overt shape. So if the person has got an oval face, you select an oval teeth or rather ovalish teeth. Patient has got a square face, use a square teeth like that. Now see, the point is, so how do you do it? You select a tooth according to the face shape, okay? Then you take one tooth from the pad, okay? You think, okay, this person has got a square face. So let me go and take a tooth which is more squarish. Take it off from the pad, put it under the lip, anterior. Put it under the lip and take a look at the patient. See? Place the teeth underneath the lip with the label surface touching the lip. Now that the rest of it is actually your clinical judgment. Now that cannot be taught, cannot be cannot be conveyed to you because the only thing that can be conveyed is the shape of the face. Because there are, and that also is not accurate because not everybody has got a pakka square face, a pakka oval face. It's not like always there is a combination. So the selecting the shape approximately, if you think it is ovalish, select an oval shaped teeth, but the- put it under the lip. Take one tooth from the pad, put it underneath the lip, like as if it is like a denture, and then stand a little away, hold it with your hand, stand away, and have a look at that. Whether this looks okay, whether this is okay for the patient. Now that is something which is subjective. Okay, and then if you want, you can ask the patient what type of teeth you had. You say it is the broad. If the patient says that my teeth were small or my teeth were broad, okay, that gives you a clue about what to do. See, this is a, I'm sorry to say, this is a gray area, right? It's a gray area. You can only have guidelines. One guideline is the shape of the face. Shape of the face is also variable. You can't have same shape. All the textbook shapes don't come in real life. There are variations. So ultimately, it depends on your judgment, but you can use the shape of the face to come to a certain point. After that, it depends on you, your critical judgment. Check whether this is all right or not. Ultimately, if you select a teeth and put it for your trial, and if the patient says, I am not happy with the size, so doctor, this is too small or this is too big, then you have to change it. That's all. There is no other way. Understood? So your question is very very valid. I know, but this is the only way. Unless of course you use the current modern technology to predict the shape for you. Till that time, it is a uh, what shall I say, hit or miss. But of course, that's why I said trial is important. At the time of trial, the patient can give their opinion. If that opinion goes against your selection, change the teeth. That's all. That's the only way to correct it. Otherwise, it's difficult. Hello? Can you hear me?
Yeah, doctor.
Yeah.
Thank you. And other question is that how to correct overextension during final processes insertion.
That is a good question. That has got a more concrete answer. Oh, yes. How to correct overextension? That's a good. Okay. How to do it? Now there are two ways. There are two things, two materials you can use for finding out the overextension first. Okay. One is we can buy from the market, but it's a pretty expensive material. It's called pressure indicating paste. You can buy it on the net or somewhere. It's available, but I think it's a little expensive material. And so we can make a cheaper version of that. What you do is on a glass plate, okay, you press a little zinc oxide paste from your zinc oxide impression packet. In that packet, you have zinc oxide paste and you have eugenol paste, right? Take out the tube with the zinc oxide paste, not the eugenol. Squeeze out a little bit of zinc oxide paste onto the glass plate. Yeah. Okay. Mix that with, let's say, a generous amount of Vaseline. Vaseline, or if you can use coconut oil also. Coconut also you can use. Because it becomes a very smooth, free-flowing paste, white paste. Okay, you remove so you take the whichever upper or lower, the border, dry it. Use a brush, a small brush, no painting brush, and take this material from the glass slab and paint the border of your denture. Paint it. Okay, or if you identified one particular area, paint there alone. Carefully insert it into the patient's mouth. Take care that on its way to inside the mouth, does not touch anywhere, so otherwise this material will get wiped off. Once it is seated, do the border molding. Pull the cheek outward, downward, inward, whatever. Then carefully remove it. One time is enough. Carefully remove it from the mouth. And the area where there is overextension, the material would be wiped off to varying degrees. Okay? And that wiped off area, you trim again. You trim. Okay? Then we know it's correct. Again add the same material. Again do the molding. Till such time that the material is not wiped off, but it leaves a very thin layer on the body. This is the best method to do it. Hmm? But this is the method to do it. Otherwise, please don't okay, yeah, this must be the region, so I will try that region, take it out and trim it like that. Inevitably, you will go wrong. You will identify where the problem is and then relieve that area. And this is the method to identify. Otherwise, you can buy pressure indicating paste. That's a fantastic material, a little expensive, but this is a cheaper version. What I told you. So that's how you identify it. Correct.
Thank you, sir.
Ah,
One other question is that
yeah.
uh, give us an insight about mandibular border molding.
Uh-huh.
That's what they have asked, like
What is the
how
question?
to do how to do the mandibular border molding.
Okay. Oh, yeah, yeah. I know how to do it. All right. You adjusted the tray. The extension has been checked. 2 millimeters short of the functional sulcus. Okay. The patient is moving the tongue out. The tray is staying there somewhat. Buccal, lingual, buccal, everywhere. You are correct. Now you take out the tray from the mouth. Soften green stick. I am using the green stick technique now, not the single method. That is that you can do when you want. I am not going to do that. Now, where will you start? It's better to start with the distolingual border. Now, you will ask me why. The reason is the distolingual border is the difficult border. Now, why is it difficult? It's difficult because in this area you are working blind. You cannot do anything. You ask the patient to do something and you get the result. For example, distolingual border, you are supposed to ask the person to take the tongue out. Now, obviously, you can't put your hand in the mouth and pull the tongue out. That will not work. That will be too much. Okay? Now, whether the patient does the properly tongue out, removes the tongue out or not, is not in your hands. You can only tell the patient, oh, please put it out. Okay? So that's why I said you're working blind. Whereas if you come more anteriorly, you are in charge. You can push the teeth out, teeth up, teeth inside, lip it out. You do it. It's under your control. The other is in the patient. And the patient doesn't do what you want, you are in trouble. So now, do it in the beginning. Why? Partly because you are still fresh, right? And partly because patient also will be able to do this. Otherwise, after doing everything else, if you do that, the patient is tired. So do it. Start with the distolingual border. Why I am saying this is specifically because in the textbook Boucher, where the picture everything is given, in that book they start from the front, the anterior, labial. And then many colleges they teach like that. That's okay, but these are reasons for doing it distolingual first. This is the logic. So you put green stick there, the distolingual border, put it in the mouth, ask the person to thrust the tongue. You press it down firmly, don't take your fingers off. Ask the person to thrust the tongue out maximally. Then ask the person to lift the tongue and touch the hard palate. Maximum outside, then lift the tongue. And some people say ask the person to swallow. But with your fingers in the mouth, how the person is going to swallow, I don't know. But you can try. But these two movements you must do. Put the tongue out maximally, lift the tongue and touch the heart. Distolingual I am talking about. Alright? Now take it out and examine. I told you the border must be smooth, round, dull finish, etc. That's a distolingual. For the mesiolingual, we usually do one side at a time. Right? One side you complete and then do the other side. That will be easier. So what are the movements? Lift the tongue again, touch the anterior part of the hard palate, the other was posterior part, anterior part of the hard palate, and ask the person to touch the tip of the tongue to either cheeks, to this cheek, to right cheek and left cheek. And maybe you can ask the person to move it out also, but that is not essential here. But side to side cheek touching is important, and lifting the tongue to touch the anterior part of the hard palate is also important for the mesiolingual. So take it out and see. If it is molded correctly, yes. Go to the other side. Okay? So the lingual is over. When you come to the buccal, again, distobuccal, start with the distobuccal. Outward, move the cheek outward, upward, inward. Upward, outward, upward. The upper it is outward, downward, inward. Here it is outward, upward, inward. Then move anteriorly, Again, outward, upward, inward. Do it on the other side. All right. Fine. So everything you have done. No, that's not enough. How do you know it's correct or not? Put it in the mouth. I told you. Take your hands off. Ask the person to touch the half open mouth, touch the upper lip with the tip of the tongue. Don't ask the person to push the tongue out, because if you push the tongue out, any bottom mold, even if it is done by Bauschel himself, the tray will come out. So and then you ask why only tip of the tongue on the upper lip, because up what we are telling the patient indirectly, we are not telling it. Up to here, I can guarantee you the denture will stay there. If you are insist on moving it beyond this, then it is not my problem, it is your problem. But I cannot make it stay there if you move your tongue in all sorts of ways. That will stay, that depends on your neuromuscular control. Up till here, I will do it, I can do it. And that's only possible. That's only, up there only you can do it. Even if you want to do it more than that, you can't. Now, if that is not lifting, if it is lifting, that means there is some overextension. So you will have to reheat the lingual border and repeat the molding again. But again, I am telling you, whoever asked that question, I don't know the name of the person. Is there a name for that person? If you have a name with that.
Yes, doctor.
What's the name?
One. No, there is no. There is just Dr. RK.
Doctor RK. Okay. So RKG, the thing is,
Pradeep.
Pradeep. Okay, does it Reddy?
Yeah.
It doesn't matter. Whatever, Reddy. Okay. So Reddy ji, the point is this, right? You can only do up till there. Anything beyond that is the patient's responsibility, right? And if it is lifting, do the molding again. Now that's what I was trying to tell you. That's, see, all this is okay, provided you have adequate ridge. If the ridge is flat, okay, or the height, then none of these things are going to work. You can try, you can do the molding, get it molded and all that, shape, everything good. But if the ridge is very poor, you cannot do anything except do what just the procedure I told you, and then leave it to the patient's neuromuscular control to make it comfortable for the patient. But the important thing is, please tell the patient that this problem, and before you start the entire thing. Before even you start the primary impression, tell the patient. See, I cannot do more than this. Your ridges are not up to the mark. And you will take a mirror and please, one more thing. This is for the young, they will tell you. It's your regular practice, I'm telling you. Maybe you are doing it, I don't know. Please give a mirror to the patient and ask the patient to hold it in front of the face while you point out what all treatment the patient requires. Because patients sometimes don't believe that they have a cavity, they have a calculus, or they have some problem. They don't know, they're not aware. When you point that out, they sometimes think that you are just, trying to be smart. So similarly here, give a mirror to the patient and show the patient, see, this is your ridge. This is flat or semi-flat. So your lower retention will be compromised. And it is up to you to have some patience and use the denture. And in 2 months or 3 months' time, you will be able to work with it nicely. Because at the end, if you say all this, the patient will think that you are finding excuses for your lack of competence. So, beginning itself, make it very clear. And if the patient is not happy with that, fine. Please think and come back. Don't. I know sending away patients is not a good idea, But what to do now? Or is it worth your time and trouble and energy, okay, to do something to the best of your ability, and at the end have a dissatisfied patient, a complainer who will make your life miserable, won't listen to any of your excuses, any of your reasons. Make it clear in the beginning. So what I am telling you, bottom loading is for a person who has got an adequate reach, not too bad. Then you can try this trick. It is very flat. Even if you touch the tip of the tongue and lip also, it's going to come up. So that is that's where you have to talk to the patient before. Otherwise, you can follow what I just told. I hope RK Riti, Riti is it?
Pradeep, sir.
Pradeep, oh, I'm so sorry. Pradeep, is he still with us now? Is he there?
I guess yes.
Fine. So I want to thank actually, they all deserve a big thanks because sitting so much into the night, listening to this. Anyway, yeah. And anything else?
Thank you, sir. Thank you. Actually, I think we are over with the questions,
Ah,
and I guess we can wind today's session, sir.
hopeful. I am ready. Yeah. So I don't know. Allah, my thing is, see, all this is all theoretical. This thing. Hmm. I wish I don't know. It's not difficult. It's practical, but that I wish some practical things can be done. But it's difficult. And I hope the audience, whoever listened, got may- some ideas. I hope. I don't know. That is for you to find out and let me know if you can whether they are benefited from sitting for 2 hours. Did all of them sit for the whole time, or some of them must have left? Hello,
Uh, yeah, doctor.
pardon.
People were listening and asking
Uh,
questions too, sir.
ultimately,
Participants were listening actually.
oh, thank you very much. Please thank them for my behalf if they are still listening. Please thank you very much for staying with me. It was a long talk actually. All right.
Thank you, sir.
So
Thank you to all the participants
yeah,
who has spent time with us, and thank you, doctor, for your valuable time. And it was very well explained in a detailed manner, doctor. Thank
okay.
you. Thanks a lot.
Thank you. Have you put this on YouTube or something?
Yes, doctor. Actually, we were going live stream, and till now, live streaming was continuing.
Okay. So suppose I want to see it, what should I do? Suppose I want to see myself.
I could share the link with you, doctor.
Please. Okay. So thank
Yeah,
you.
sir.
Your name,
Thank you, sir.
your name. Sorry, once again, your name, please.
My name is Fajna, doctor.
Firstna. Okay. Thank you very much, Firstna, for being with me and helping me out with this technical business. And I
Yeah.
sincerely hope that people have got some benefit. I don't know. So I hope.
Yes, sir. Sure, sure.
Okay. Right. So good night.
Okay, sir.
Okay, good
Thank you.
night. Okay.
Good night. Good night, everyone.
And please send me the link for the YouTuber so that I can see for myself what I
Yes, sir. Yeah. Yes, sir.
okay.
Thank you very
Okay.
much, sir.
Pardon? Thank you. Is that Shanuf?
Thank you very much, sir, for great presentation. Thank you.
Is that Shanuf talking?
No, no, no. It's not Shanuf. It is Pradeep, the one who have put forward the
Question.
mandibular question.
Okay. Where are you from? Kerala, Trivandrum, Pradeep?
Uh, from Chennai, Arakkonam.
Oh, Chennai. Oh, okay. Hope you understood what I said.
Yes, sir. Yes, sir. Very much understood. Great presentations
Oh, thank you very
and
much.
great learning clinically.
Ah, right.
Thank you, sir.
So good night. So good night. Bye.
Yeah, sir. Thank you. Thank you. Good night, sir.
Good night. Good night.